Hi, and welcome to the next instalment of the Oxford Centre for Personalised Medicine Flash Interview Series, where we talk to different individuals playing important roles in personalised medicine. Today's guest is Professor Bill Newman from the University of Manchester and the Manchester Centre for Genomic Medicine. Hi, Bill. So can you start by telling us a bit about who you are and your background?
Sure, thanks, Catherine. So I'm Bill Newman. I'm a clinical geneticist. I trained in medicine in Manchester back in the 1980s. I then studied adult medicine before training in clinical genetics. I then went off to do a PhD looking at the genetic basis of our osteoarthritis, and then moved to Canada where I did a fellowship in Toronto. I came back to Manchester and have had an interest in rare disease genetics, so trying to identify the genetic basis of rare diseases, and also in an area of medicine called pharmacogenetics.
Brilliant. So if I say personalised medicine, what does that really mean to you?
So when I think about personalised medicine, obviously as a geneticist, I think that very much focuses in on the genetic aspects of that, although I appreciate it can be broader. And I feel it's about using genetic information to tailor a person's treatment to them in an individualized way. So using their genetic information to make their treatment safer or more effective. And that's what we think about, particularly when we're thinking about pharmacogenetics.
So with this special interest in pharmacogenetics then, or genomics, can you tell us about any projects in the field that you've been involved in recently?
Sure. So I've been involved in a study called the PALO study over the last couple of years. And this is a pharmacogenetic test where we've known for the last 25 years that about 1 in 500 people carry a genetic variant in their mitochondria that increases their risk of severe irreversible hearing loss if they're given the antibiotic gentamicin. So lots of people are given gentamicin. It's a very commonly used drug, and it's used very widely in newborn babies to protect against sepsis. And when a baby comes onto the neonatal unit, they need to be given their antibiotics in the first hour. So normal genetic testing, which takes 2 or 3 days in a laboratory, just doesn't work. So we've made a point of care test, which is based on LAMP technology, where you take a cheap swab from the baby, you pop it into the machine, 25 minutes later, you get a result telling you whether the baby carries the variant, yes or no. And then the doctor is able to use that information to inform the prescription. And so we did a study to see if that would actually work in practice. And we tested 750 babies. We identified 3 of them as having the genetic variant, so a bit more than the 1 in 500 that we were expecting. And those 3 babies all got given a different antibiotic, which was great, and that antibiotic works well. And the only reason we don't give that antibiotic normally is because we're worried about antibiotic resistance. And so that's why we stick with gentamicin. And the other really important thing was that we found it was the nurses that were doing the testing, and they'd be doing it at 3 o'clock in the morning, or at different times of the day. And they always did the test on time, and it didn't delay the baby's antibiotics. And so there wasn't any waiting around or any mix-ups. And so that's really important to embed that testing within personalized care. And so we think that this is the first example where a pharmacogenetic test has been used really quickly in clinical medicine to change clinical practice. And now we're starting to work with colleagues to roll it out across the whole country. And we've had colleagues in America and Australia and the Netherlands wanting to start to use the test, which is great. And we're thinking about other areas of medicine where you might need a result really quickly. So that is for particular for patients needing rapid surgery. So would a genetic test tell you about what safe anesthetic to use? Or for patients having a stroke, there's a particular drug called clopidogrel. So there's a paper that came out in the New England Journal of Medicine yesterday telling us that lots of patients who are given clopidogrel carry a genetic change that means that it just won't work in them. So maybe even up to 50% of people in some parts of the world, this drug won't work. But what you need is a rapid test to be able to get people onto the right medicine. And then if patients have got pain coming into accident and emergency, we know that about 10% of people get significant pain, and that's not solved by codeine because they've got a genetic basis for that. So we're thinking of lots of ways that we can use this new technology to personalize people's care.
Brilliant. Thanks so much for discussing this incredible point of care project. And I guess it really shows how collaboration between researchers, clinicians, nurses is essential for implementing personalised medicine. So finally then, looking ahead, where do you see the field of pharmacogenetics and personalised medicine more generally in the next decade or so? And what do you think the biggest challenges would be towards progress?
Oh, great question. So thank you. It's what I spend a lot of my time thinking about. I think that we will be using pharmacogenetics far more. I think we're looking to try to roll out more general pharmacogenetic testing in hospitals and in primary care, especially with GPs, because the vast majority of drugs are prescribed by GPs, particularly things like antidepressants, painkillers, commonly used drugs where we know that genetic information can help us work out safer, more effective prescription. I think a big challenge is obviously the cost, making sure that the information that we provide from these tests is very clear, so a doctor knows exactly what to do with the information, and then embedding it into a patient's electronic patient record so that that information follows the patient around and is always available. So rather than a patient coming into hospital and then needing a test, what you do is you'd organize testing on everybody, and then they would have that information so that if they ever needed healthcare or access to medicine, that information would be available in a preemptive way. And I think the technology's there, the costs are tumbling, and it just takes a little bit of organization and motivation, and we'll get there.
Brilliant. Thank you so much. Have you got any final comments that you want to make?
No, I just think that it's a really exciting area. I think that pharmacogenetics has got lots to offer, but the most important thing about safe and appropriate drug usage is making sure that people take the right drugs for the right illness and in the right dose at the right time. So pharmacogenetics is a part of that medicine management, but it's not the whole story. And so I'm always conscious that if patients take their medicine in the right way and they stick with the instructions, then they're in a good place.
Wonderful. Thanks very much for your time.
All right. Thanks so much, Catherine.